A patient of heart rate of 180 just rolled into your resuscitation bay. Would you slow the rate or shock the patient? That single decision can save the patient's life. The first priority is never the ECG, it's the patient himself. Start with ABCDE assessment, attach the monitor, obtain a 12-lead ECG, establish IV access, correct reversible causes, and give oxygen only if saturation is below 94%. Now, ask the most important question. Is that arrhythmia causing life-threatening conditions? Shock for shock, ongoing hypotension, syncope, myocardial ischemia, acute heart failure with pulmonary edema, or the immediate post-stroke patient? Answer is yes. Don't delay. Perform a synchronized cardioversion immediately. Deliver up to 3 synchronized shocks, ensuring R-wave synchronization every time to avoid precipitating ventricular fibrillation. If the patient is conscious, provide sedation or anesthesia whenever possible. Cardioversion fails, move quickly to antiarrhythmic therapy. Give amiodarone 300 mg IV over 10 to 20 minutes or procainamide 10 to 15 mg per kg up to 1 gram over 20 minutes. Then repeat synchronized cardioversion. What if the patient is stable? Now, the ECG guides your next step. First, determine whether the QRS complex is narrow or broad. Then, decide if the rhythm is regular or irregular. Regular narrow complex tachycardia begin with vagal maneuver. Unsuccessful, give adenosine in escalating doses. 6 mg, then 12 mg, then 18 mg, provided there is no evidence of pre-excitation. Still no improvement, consider a beta blocker or verapamil, and at any time if instability develops, proceed to synchronized cardioversion. Irregular narrow complex tachycardia is most commonly atrial fibrillation. Focus on rate control, tailoring therapy to the left ventricular function, and always consider anticoagulation if lasted more than 24 hours. A broad complex tachycardia should be treated as ventricular tachycardia until proven otherwise. If regular, manage with procainamide or amiodarone when appropriate. Remember, adenosine is only reasonable when SVT with aberrancy is strongly suspected. If it's irregular, think of pre-excited atrial fibrillation or polymorphic ventricular tachycardia. Avoid AV nodal blockers and intercept points. Give IV magnesium while correcting the reversible causes. In emergency medicine, rhythm recognition matters, but recognizing the unstable patient matters even more. Thank you for watching and keep learning. Think fast, act right, save lives.